Welcome to the first of a three-part webinar series, Coordinated and Collaborative Responses, Infants Experiencing Family Violence. My name's Michelle Perry and I'll be your facilitator this morning. Next slide, please. Can I first start off by acknowledging the traditional owners of the land on which we're meeting. We're meeting across the lands of Victoria, maybe even further afield than Victoria, I'm not sure. I'm meeting you today on the lands of the Bunurong people, and I would like to pay respects to elders past, present and emerging, and in particular any Aboriginal colleagues that we have with us today, either on the panel or tuning in to the webinar. So if we could go to the next slide, and as I said, I'm part of this three-part series panel discussing a very important topic around collaborative practice, working with families and with the eye of having of the children. So today's conversation, we're going to explore the unique family violence risks and considerations for infants. So infants, we're going to put it in this particular context will be 3 and below, and we'll be using a case study to keep us on track with that. The other the other two parts of the webinar will be looking at working with children and then working with adolescents. And that's just with the idea that we know that we can't always just talk about children in context of just being children, because the needs of infants are vastly different from those of older children and of adolescents. So we're going to be maintaining a focus on the infant experience, and then we're going to look at how to collaboratively manage family violence risk to infants. Can I just say that today we're going to be talking about quite a sensitive subject, and there may be some triggering issues that come up for you. I'm just going to remind you all to take good care of yourself as you watch this webinar, and reach out for support if you need it. So I'm lucky enough to have 3 expert panelists with us today. And I'll introduce our 3. Katie Meehan is the practice specialist for family violence and child safety at Relationships Australia. Sherelle Jackson is an outreach coordinator at Elizabeth Morgan House. And Luke Doherty is the team leader, family services at Family Life. And I've jumped ahead in my PowerPoint, so if I can go back. That's it, I'm on track again now, that's good. So today we're going to be talking about, as I said, the unique experiences of infants in regard to family violence. We do know that there are serious impacts on infants, on children and on adolescents, but in this particular case, infants. For their developmental growth, their emotional, physical and psychological well-being. We do know that when a child or an infant is in a family experiencing family violence, they are victim survivors in their own right. And this has been clearly highlighted in changes to do with our Family Violence Act here in Victoria. We know that there are children victim survivor services that work directly with children, that have an understanding of their unique experiences and the trauma that they the effect of trauma on their lives. But what we're going to talk about this morning is just how, with the MARAM coming in, we have a responsibility as practitioners, all practitioners, to consider and respond to the needs of children. And so how do we do this if, in fact, we may not even engage with the child directly, or have any specific specialist knowledge of how to do that. So that's what we're going to be exploring this morning. And jump a couple of slides. Okay. So here's a case study that we're going to use, and I'm just going to read through the case study very quickly, and then I'll put some questions to our panel. So Monique and Toby are married and have 2 children. Max, age 2, and Kiara is newborn. Monique identifies herself and her children as Aboriginal, and Toby identifies as Irish Australian. Family Services received a referral for the family from Child Protection for the purposes of building strong attachments with the newborn baby and a safe and supportive home environment. Information provided in the referral described family violence perpetrated by Toby, including a violent incident with a weapon during Monique's 3rd trimester, in which a neighbour called the police after hearing shouting coming from the house. Police completed an L17 report, and Monique was referred to a specialist family violence service. Toby was removed from the home, and a full intervention order was issued by the police. 5 hours later, Monique went into labour with Kiara. Monique made a successful application to the court for the IVO conditions to be varied to allow Toby to reside in the home, on condition that he not perpetrate family violence. Toby also self-referred to a men's behaviour change program as a voluntary participant. Visiting the home, the family services worker observed that Toby spoke on behalf of Monique, made comments that undermined her parenting, and became visibly agitated when Kiara was crying and Monique left to care for her. The worker also contacted the maternal child health nurse, and who described similar concerns about Kiara's wellbeing and development. The worker contacted the MBCP, the Men's Behaviour Change Program, to determine if Toby is attending the program. They said that they shared that they observed Toby may have been drinking prior to one of the sessions. Additionally, Toby demonstrated challenging and inappropriate behaviour in the MBCP group, in particular, the use of comments about Monique and the children's culture and community. Monique has declined family safety contact support, but continues to be supported by the Specialist Family Violence Service. So that's our case study. And we're going to put the PowerPoint away. And my first question to the panel, and I'm going to start with you, Katie, is what are the family violence risk and protective factors that exist for Max, who's 2, and Kiara, who's newborn, in this situation? There's 2 parts to this question. So what are the risks, factors, the protective factors, and what more do you need to know in risk assessment at this and response?
No, thanks, Michelle. Look, I think when looking at the MARAM, I guess I'll be drawing on Pillar 1 in particular and Pillar 3 just around making sure that there's a shared understanding of family violence and also around responsibilities for risk and management. So when looking at the risk factors for both these young children, I think that one of the key points that stands out is the use of a weapon by the perpetrator in the presence of the children, and being aware that that is a high risk factor under MARAM. We would be concerned around the children's exposure to emotional abuse. I think that looking at the case study, and just wanting to know some more information. We'd be really keen to understand how the children, I think looking at the impact on the children and their development is, some information that we would, be really keen to know as a specialist family violence service. And I guess, probably looking at Max in particular and how he interacts with the perpetrator in the presence of his father might be a key point to look at, from a service point of view.
Thanks, Katie. Luke, what else could you highlight there?
Yeah, I think that there are a number of risk factors like Katie touched on in relation to the weapon. I think the information we gathered from the MBCP practitioners that Toby presented as alcohol affected during the session gives us insight into the seriousness that he actually places on his behaviour. So he's not participating in that program with a necessary want to change. He's seeing it as a kind of a process. And I think the other thing there is, which we got from the MBC practitioners, is the intersectionality in his use of violence and the inherent racism that he has towards his wife and therefore children and their identity. And so what we can look at there as well is the long-term impacts on the Max and Kiara growing up, with seeing their father using racism against their mother and the impact that will have on their development and their sense of healthy identity of who they are as people. So I think there are a couple of other risk factors. I think in terms of protectives, what we're seeing, in terms of protective factors, what we're seeing there is Monique has developed a really in tune way of noticing Toby's triggers and acting to prevent escalation, where it talks about when on a visit, Toby, one of the children started crying, Kiara, and Monique immediately went to tend to her to prevent that from agitating Toby further. So we can see that Monique is putting a lot of really important strengths in place to keep herself and the children safe.
So what I'm hearing already is that a lot of the questions you'd be looking at really aren't directly connected with the children, but it's about what type of capacity that the parents have to parent. And there's also a consideration there for not only immediate risks, but that projected long-term impact of, as you said, the racial slurs and things like that. So that's interesting. Yeah. Sherelle?
Yeah, look, I think that Katie and Luke have really covered some of the family violence risk. But I think if there was any additional ones, I'd be thinking about the escalation of violence during pregnancy, and if that has had an impact on the impact on the newborn child, as well as, there seems to be controlling behaviours, especially towards the intervention and undermining the parenting as well. And because there has been an escalation, some of the protective factors that I can see is that she has applied and accepted to have the intervention order buried. And I also think that having some services, like the maternal child health nurse, and accepting the referral for the specialist family violence service, I think it's a protective factor as well. And that there are a lot of services monitoring the family and the family dynamics. Like what Luke was saying, there is the maternal child health nurse, there is the men's behavioural change program, and we're able to see all the different types of family structure and seeing how we can best wrap around the support. And in terms of the risk assessment, what more do we need to know? I think that is, a bit more about the children's I just lost my train of thought. But just thinking about the children and, what questions we need to be asking the mother as well, and what extra additional information that we want to know, especially what was happening prior to the newborn birth as well, if there was any other risk factors that happened prior to the newborn being born with Max as well. So I think there's a lot of different additional factors and a lot of additional layers that we need to consider when we're working with this family.
So that's another consideration is not just dealing with the children as they are now and the projected trauma in the future, but what happened in the past, in particular with, before the birth, and how did that impact, how does that impact on the child now? So very important. And Sherelle, you mentioned, there's a lot of services involved in this case. I'll just go through. There's the family services. There was child protection. Police has been involved. You've got the specialist family violence service involved, the court, men's behaviour change, maternal child and health nurse, and family safety contact support to some degree. So, Sherelle, if I can stay with you, how would your organisation, collaboratively work with those services in this case, and keeping an eye, with the purpose of keeping an eye on the children in this situation?
Yeah, I think it would be who is holding the specialist safety planning. When you're thinking about it being a specialist family violence organisation, is really calling care team meetings, ensuring they're happening, professionals meeting, as you said, bringing everybody's information interview as well, and thinking about how we would use the FIS and the SIS, the information sharing schemes in this position as well. And I really do think that when we are, holding the person using violence in view at all times, and as we said, part of the MARAM is the self-assessment risk of the mother as well, with what her risk of the children are. I think we need to really hold that interview, and that's a big part of the MARAM as well. And I just really think that keeping constant contact with each other, working out who's holding those specialist information. So if we're the specialist family violence, who's going to be working with the children, and if we need to be bringing in specialist children's services, and where we need to be working towards keeping those children in view.
Luke, what particular organisations would you be, in your organisation, be looking at working with?
Yeah, I think much like Sherelle said, I think that professionals meeting, coming together to look at it. I think one of the things that I'd certainly be recommending is completing what used to be a section 36, now a section 193, to information check on Toby's backgrounds. So through the orange door, getting a history of has he had previous relationships where there's dynamics with family violence. What does his perpetrator pattern look like? We need to start seeing what makes Toby tick, what's happened before, because that can give us a good indicator of some of those behaviors that might be a pattern and raising concerns going forwards. I'd be wanting to getting the information from child protection about, are there any previous history? Has there been any other concerns reported? And then I think it's about, working really closely with that care team who's seeing the family. What does the communication with mum look like? Is, if you're sending messages or making phone calls, is Toby the one engineering those text messages back, or is it coming from Monique? I think it's all things that we need to be really mindful of, because we can see that Toby's controlling behavior is running quite deep, and there's a high level of manipulation going on there. So we found out from the men's behavior change about the racism in the relationship, but Toby hadn't necessarily presented that to the workers. So he's probably quite skilled, and he's showing us what we want to see as opposed to what's really happening behind closed doors. So all of that in mind with how is he responding as a parent? What does he see his role as a father, and how does he want his children to see him? If he was to be told about, you know, the elements of the violence that he uses and the trauma that can cause for the children going forward, is that what he wants for them? And does he understand how his behavior impacts on their development?
So the things that often keep family violence hidden are in place here with, you know, don't tell, you know, people what the family really is experiencing, you know, show a facade that everything's okay, and you want to get at the truth. And you know, the consideration with infants is that they can't articulate, nor should they have to be responsible to explain that truth. So you know, the information sharing is about highlighting what's really going on.
Yeah, that's exactly right. And I think that we need to be mindful of the way that Monique presents. Is that her true wish, or is that her operating out of fear and what she's been told to say? So, you know, she might be saying how great he's been, but that's out of fear of losing the father figure. There's still a real stigma for a lot of families out there around separation. So we need to be mindful of what's driving that, and looking at the different elements behind it as well, the cultural implications. So I think that's another service that I'd be looking to talk to, bringing in Aboriginal specific services to do an ALW consult to make sure that we're taking into consideration the Aboriginality and any cultural supports that we can make sure we're putting in place to support Monique, Max and Kiara as well.
Katie, any thoughts on further thoughts there?
Yes, I think one of the key, and I really agree with what Luke and Cheryl have said and touched on, and I think that the involvement of the maternal child health service will also be, be a really key service to, have the, I guess, eyes on both children, especially if they're able to visit at the home. I guess just some further thoughts I had, on this point as well is when we're working with, both the perpetrator, for example, in a men's behaviour change program, either both during the assessment or during our sessions, we might ask questions, sort of around, based on curiosity, and try to gauge a sense of how the perpetrator, how the father might view their child or children and their relationship, and that can often be a key indicator for us around their use of abuse or violence in the home in front of the children. I guess, a couple of key phrases or points that we are mindful of is if the perpetrator refers to their child as, he's my son, or in a way that objectifies the child to demonstrate, they might be using, that real coercive control and treating the children as an object rather than focusing on their role as a healthy sort of protective father in that setting. We might ask them sometimes during an assessment to describe their children, like provide a mini profile of their children to our staff, so we can get a sense of what they understand about their children's development and what, how they can tell us about their children. Sometimes the less information they tell us, it's often an indicator that they're not, heavily involved with the raising or the physical rearing of the children. And when we ask them to describe their behaviour in front of their children, that can often be a really, I think what we found over time, common themes are they'll often dismiss their behaviour in front of the children, or sometimes the insight into how their behaviour can impact the children and their development, is concerning. So they're just some cases we tend to, try to pick up when we're working with the perpetrator. and when we're working with the mother of the children, in this instance, you know, we would also ask similar questions around curiosity, but ask her to describe, you know, her view and her observations of the father's interaction with the children, you know, both directly and in front of, and try to gain a sense of what is happening in the home, you know, that has the potential to affect the safety and development of both children. You know, always being really mindful of what the, you know, sometimes the oldest child is doing in an incident such as this. You know, is he hiding, or is he, you know, if the little baby was born at that point, would he be trying to protect the youngest Kiara? Yeah, so I guess lots of, you know, themes to explore with both mother and father in different settings within these services involved. And I guess always having that consistent and collaborative practice, you know, being one of the key themes and pillars at the forefront of our minds, you know, particularly coming from a, you know, an NBCP service that, you know, coming out of the Royal Commission and having, you know, the focus really being on perpetrators and the location and knowledge of perpetrators and what they're really doing, you know, being a key point from our work over the last few years, you know, really standing out in that way.
So, Katie, you were saying that you'd asked the mum, you know, how did the children respond in this, you know, when it was Max hiding or protecting his sister. Would you ask those same questions in the men's behaviour change to the fathers and saying, you know, when this was going on, what was happening, where was Max, how did he respond? Is that a conversation you would have with him as well?
Yeah, we could certainly have, you know, as a group session, you know, we can ask that to the group. You know, I guess as you can imagine, there'd be some, there may be some men that, you know, happily share that information and others that, you know, remain quiet. We find often that when we do the sessions on the children, that can be a pivotal moment in the men's lives, particularly for those men that are really looking genuinely to change their behaviour. So when they have sometimes that light bulb moment where they can start seeing, you know, oh gosh, you know, my behaviour, you know, has potentially had an impact on my children, that can often bring with it a lot of emotion in the session. Sometimes if there's other men in the session who are also there, you know, generally wanting to change their behaviour, it can sort of be like a joint moment for them where there's, you know, quite a fair bit of emotion running. And I guess, you know, there's several things for us to consider, you know, a couple of those points being, how do we, you know, help support them appropriately whilst not condoning what's happened, but helping them move through, you know, that immense guilt and shame that they often experience, helping them work through that in a healthy way. You know, it's a pretty common feeling to experience that when in their shoes, and so be it. But we need to get them through that so they manage it in a healthy way and not revert to unhealthy ways of managing those responses. But it is important in their journey that they realise the impact of their abusive behaviour on their children, because we just try and do the best we can to stop the cycle, you know, through the generations. So those moments and what the other men learn from that in the sessions can be, you know, it can be life-changing at times. So, and it can often, you know, also come down to the skills of the facilitators in that room and how they manage that. So, yeah, it can be a big question and quite a complex session that unfolds and yeah, important work though.
Yeah, thank you. Now we've already talked about, and you've already mentioned the use of the MARAM. I'm going to get focused back onto the case study now to ask, first I'll ask you, Luke, at which points in the case study could a MARAM family violence risk assessment and safety plan be triggered, have been triggered. So at which point in that process of the family, and what would be the considerations for safety planning for children as they are infants?
Yeah, look, I think that the MARAM can be triggered from the very beginning, from the moment that the police arrived at the home. That's when we need to start unpacking and assessing that risk from the very beginning. I think that I look at the MARAM as not a sort of one-off assessment, but it's a living document that needs to be continually viewed and re-looked at every changing dynamic in the relationship and at every piece of new information. And I think, you know, the great thing about MARAM and that the collaborative practice is that at all times you're seeking more information that will help us to fill in that puzzle and to see the whole picture. So, you know, we'd be looking at the MARAM and then adjusting it as you have those conversations with what's the maternal child health nurse observed in that setting, because she's been going into the home and doing those initial checks for Kiara. What's been observed in the men's behaviour change program, what's the family violence worker seeing, so that we're not coming up with, I think what we know from the Commission is that at any time there's multiple services involved in these families, but we all hold different pieces of the story and different bits of information. So we should be all working together in terms of completing MARAM and making sure that we're assessing the risk as it changes. Risk isn't static, it's fluid and it changes day to day. We don't know a lot in the case study about Toby's other circumstances. Is he working? Is this happening during COVID? Is he laid off? And what's that impact on his mental health? What's the past trauma history for mum and the children? It's important to hear Toby's story as well, but also not to let it become an excuse for his behaviour. So at all points, we should be checking in with one another and reassessing. The safety plan, again, hopefully has been triggered when the police arrive, and if not, certainly when the courts agreed to vary the IVO to allow Toby back into the home. I would have been hoping that while Toby was out of the home, there was some significant safety planning, because we also know that the most risky time is when a victim survivor leaves the relationship. So that's inherently increased when Toby's removed by the police. There's a lot of anger likely to be there. So that safety plan, again, will shift and change as the circumstances change. So when Toby's allowed back into the home, how are we making sure that Monique and those children are visible and their voice is able to be heard if the safety concerns are escalating? Like we all have talked about, the children are so young, they don't have the ability to put their hand up and say, hey, I don't feel safe here. So we need to be looking at that. We need to be gathering the information through the maternal child health as nurses interactions, family services. And we can't look at a child and make an assumption that because they're a really content baby, there mustn't be things going on, because often infants learn that when they make noise, that's when the violence happens. So they might have actually learned in those really early stages that they need to not cry, they need to not be making sound, because that triggers the behavior. So you can't take what we would typically see as being a really easy baby to mean that this baby's feeling safe and loved. The baby could be doing that as a response to the violence as well. So I feel like I've gone around the question, but hopefully that answers most of it. I think that it's a continuous process and we need to be looking at each case individually. How was that baby? Has that baby ever appeared differently? Has there been a change in their behavior? Is their development on track? Are they growing at the right rate? Because infants that aren't getting their emotional needs met can sometimes develop slower as well. So really taking into account all of those physical attributes as well.
And yeah, fascinating to think, and quite disturbing to think that a newborn baby can change its behaviour to reduce the amount of violence around it. It's frightening. Sherelle, what would you like to add to that?
Yeah, additional to Luke mentioning the police, I'd be going back further as well and thinking about when Max was born, thinking about did the hospital ask Monique about family violence, if there has been a pattern of escalation previously in the last pregnancy. So using that collaborative practice and bringing in those services like the hospital maternal child health nurse that has been working with the families for quite some time. Have they got any additional, and if they did, ask the question, and if they did it in a safe space, that would be one of my points when we're thinking about if there was any intervention back then in using the MARAM, because previously, we're thinking about the craft where children weren't brought into thinking about them as a victim survivor in their own rights as well. So I would be really bringing that back in and going as far back as when Max was born, if there was any escalation in violence back in that pregnancy as well, and seeing a pattern of behaviour and finding out if there was any other factors that we need to be considering or looking out for. And then when I'm thinking about maybe just some extra considerations for safety planning as well, when we're working with mothers, we're trying to think about being client-led. So when we're thinking about safety planning, we're thinking about if there's a situation, if they are going to reside in the home and it's not appropriate them to leave, or whether or not we're trying to pre-plan for all of that as well. So when we're thinking about if there's a situation in the home, a lot of the time the burden is on the mother and children to flee. And it's more like, why doesn't she just leave when it should be, he needs to stop using that behavior, and what she thinks is the way that she needs to protect herself as well, because she's already got, like I think Katie mentioned, she's already got her own self of safety. She's already safety planning within her own and with the children as well. There are some already protective factors in there, and she has kept herself safe for quite some time. And now it's just that services are using that intervention to support her to keep more safe and keep the children in view, and keeping Toby in view as well as the person using violence. So one of the considerations I would be thinking about is what does she need to keep with her for the children when she leaves. So thinking about the blue book, thinking about all the children's documents, Medicare cards, so then if she does need to leave, that the children can link in with the maternal child health nurse, that next day checking on the children. Does she need a special phone for safety in the bedroom with the children? So if something is happening outside and she needs to attend to the children, but obviously if there's that undermining parenting, there's somewhere else that she can use to contact a safe person like the maternal child health nurse, and using all those services as well, like the maternal child health nurse, the hospital, all of that. And they can be included in that safety planning as well. And, when we think about collaborative practice, we're thinking about how can all those services and who's going to hold that safety plan. And the safety plan is always going to be a living document, and it's going to change as escalation in violence, frequency, patterns of behaviours are identified, and how we need to be monitoring that safety planning. Who's going to hold that, especially for the children? As a specialist family violence organisation, we are not specialists with children's safety planning, but how do we bring that into view, and how do we make sure that everybody, so then Monique can have that wraparound support, that she doesn't have to keep telling her story to different organisations and saying, well, if there's that phone call of going, if maternal child health nurse rings, and one of the things is, one part of her safety planning is that if she's not okay or things aren't okay, you go, how are you? And she goes, I'm going to knit your throat. So if he's around, and that's a trigger to say, hey, things aren't okay at home, and that safety planning might have to start kicking in for the children as well. And bringing, as I said, using that secondary consultation for us is a key factor, and making sure that we're keeping those children and the infants in view.
So it's not a case of having a safety plan for the whole family, which is, what we have historically done when we've worked with victim survivor, but also looking at what does each individual child need and require in that moment. And what I'm hearing you say, Sherelle, is that sometimes we just don't have that expert knowledge. So getting a secondary consult from an organisation who does really know, you know, particularly what Luke was saying about, you know, the impacts that family violence can have on infants and how to combat that is really required.
Yeah, because like what I was seeing at the end of the case study is that she did not want to access that specialist service. So then if she only wants to work with a specialist family violence organisation, how you can still have that wraparound support even if they're not directly working with a specialist children's organisation.
So Katie, what about your organisation? Where would you be looking in the case study that would be a real highlighted area to undergo a risk assessment?
Yes, I think at the point, you know, for example, if we were concerned that Toby was attending a men's behaviour change program session, alcohol affected, for example, that would trigger a range of actions from our end. You know, I guess various possible scenarios, but you know, as a starting point, you know, the facilitators, and I get not just for our agency but in the sector, you know, generally what we would do is explore, you know, if we could have a discussion with him. If we suspected that he was alcohol affected, you know, before the session started, we would explore with him to confirm if he is, you know, I guess the physical indicators around that, what he's been doing leading up to that session, and if, you know, I guess depending on how intoxicated he seemed, what we would do after that. So, you know, generally speaking, if they are intoxicated, generally, you know, not allowed to enter the session. So, and what that looks like afterwards, you know, in an ideal MBCP world example, we wanting the family safety practitioner to have a discussion with the mother at that point, to establish, you know, where she and the children are. If we had an understanding of what the father's view of the mother and children are at that time, what his expectations of the mother is in the relationship, if she's there, you know, to, I guess, for his needs and his needs only, and disregard the children, we would be really concerned. We'd want a safety plan with her around what it looks like if he does return home after the session. Apologies, my pets are contributing to this conversation. Bear with me, sorry.
There's always one in the...
Yes, sorry about that. And we'd be really keen to have sufficient safety in place for the mother and children. And what that looks like will depend on information we have prior to that session. So, you know, sometimes having the police out can actually, you know, I think we all know, whilst we always would like that to be the safest possible outcome or option, sometimes we know when the police leave, it actually places her at further risk. So, you know, there might be a relative or someone that can pop in if he does return home to kind of, you know, keep the situation as calm as possible. We'd be really hopeful that hopefully the children, you know, could be put to bed and not hear anything as much as possible. But I guess there's a number of scenarios that can play out that we would be, as an agency, would have to explore with both the mother and father at that point in time. We'd also be following up the following days and just seeing, you know, at what risk levels are present for both, and you know, just who else, what other agencies are involved with the family, how they can help both the mother and father for different reasons at that time. If we need to do a referral for, if we're concerned about ongoing alcohol use for the father, what that looks like, and if we need to do a referral for him to support him, you know, to get help for that, you know, we will certainly assist in that way. So yeah, a number of scenarios from our agency, and all, you know, all MBCP providers in the sector that can do similar work.
Now, in this particular case, Monique has declined support through family safety contact, Katie. I'm just wondering, is that a common practice, and how then do you incorporate the family. What do you do about that?
I think, yes, no, a good question. And I think in this case, if we're concerned that she has declined our family safety support because, you know, he's, you know, exhibiting coercive control behaviours, that certainly highlights the risk to us. You know, we would be doing as much, I guess in the sessions, you know, it would often, we, you know, try and see if the facilitators can do as much work with the man in group as possible. You know, try and ensure his engagement is, you know, as meaningful and purposeful as possible, and really bring in the gendered discussions, and you know, look at, as I touched on before, just the impact of his behaviour in front of the children. And I guess the NVCP runs for 20 weeks, so it's a long time for someone to be coming to group every week, if you know, if that's what's happening. And so we'd be really hopeful to see a shift in his attitude and behaviour, you know, from the start compared to the end. So if the woman is not engaged with our family safety practitioner, we'd be really guided by the man, his presentation in the session. They often, believe it or not, do disclose if they are using ongoing violence, even when they're in the session. So, you know, clearly if that was the case, we'd certainly be reporting that to Child Protection and Police, you know, those external statutory agencies that can, you know, have some involvement. So, yeah, a number of ways we can manage it, but yeah, just my initial thought is we'd be really guided by his behaviour and his comments in the group that would guide our risk assessment, and, you know, have our facilitators really, you know, try to draw that out as well. So it's a real skill in that space.
So, Sherelle, I'm going to ask you next, in particular, how is MARAM, Family Violence Risk Assessment and Response, conducted, particularly in your organisation? But I'd like to kind of focus on the collaborative approach, in particular the intersexual practice that you might have in this particular family's context.
Yeah, so I think I've mentioned it a few times previously, but when we think about collaborative practice, it is bringing all those specialist organisations in, as you know, we're the peak body for Aboriginal women experiencing family violence in Victoria. So, you know, when we're thinking about applying that intersectional lens, we really hold their culture and safety at the forefront. You know, and when we're thinking about the MARAM, we are thinking, you know, like Luke was mentioning it before as well, that, you know, thinking about when we're talking about racism, how that's impacting on Monique and the children, and how that's going to be brought up when we're thinking about things like transgenerational trauma. Because with Toby, you know, I'm going to just mention, you know, is child protection a factor for him, you know, that he's going to use a system to perpetrate family violence. And if we're thinking about working with Aboriginal clients, you know, taking in that transgenerational trauma and the impact of children being removed is very real. It is a really real factor, and that Aboriginal children are being removed today more than what the stolen generation were. And that came out of Task Force 1000. So I think that if you're applying that intersectional lens and in practice as well, that could be a factor of why Monique did not want to accept that specific referral. You know, and that is about applying that intersectional lens in that practice as well. And, you know, really asking Monique with the children how that is impacting. You know, because I think I'd be considering, if, you know, making sure that she's got choice. And if she chooses not to use a specialist organisations like an Aboriginal one, ensuring that the mainstream one can support her and the children as well, and making sure that they can celebrate her identity as well as the children's identity. You know, how does Max feel about his identity? You know, same as Kiara, you know, she might be a newborn, but I really think that, you know, in a sense, Monique would want her, you know, identity and spirit to be celebrated in all aspects of service provision, wherever I think we're working from. So, you know, if you're not 100% sure, the same way we would use a specialist children's organisation, using those Aboriginal specific organisations as well are really important, because that means that you're, you know, bringing in every aspect, identity, and all those, you know, there is racism that perpetrators use, but it's also the system as well. So we need to be closing those gaps for victim survivors that are Aboriginal, accessing all services. And I think that's a really good way of ensuring that children are kept in view, because using those specialist Aboriginal children's organisations are really important to manage and assess risk, and applying that intersectional lens, you know, as well as safety, but then again, you know, ensuring that we're celebrating their identity, celebrating, and, you know, I think culture is actually a protective factor as well for parents and children, and that it's a really good way to think about, you know, community and organisations as a really strong wraparound of collaborative practice as well. So, you know, as much as the organisation, community is also a big part of their safety planning, bringing in the aunties, the uncles, you know, the family is really important as well.
So it's nice to know we don't have to have all the knowledge ourselves. It's just as important to identify what you don't know. And, you know, just reading something in a book, it doesn't make you an expert. And, you know, reaching out to get that expert knowledge. Luke, is there anything before we're going to finish up very soon? Is there anything you'd like to add on to that?
No, I think we've covered a fair bit today. So yeah, I don't think I necessarily have anything to add to this part. No.
That's fine. That's fine. Katie?
Just the last point I wanted to touch on within this question is just, I guess, our services, you know, being really aware and mindful of, you know, our victim survivors having, you know, additional vulnerabilities such as, you know, disability, or, you know, if they're part of the CALD community, how we engage assistance and support, you know, in that sector. And also when perpetrators, you know, present in our groups, they may also have a disability, you know, such as an acquired brain injury, for example, and how we manage that. And, you know, we never excuse use of abuse and violence, but how we manage that can also have some additional complexities to it. So, I think for both victim survivors and perpetrators, how we use and refer our clients to specialist agencies to help us manage those additional vulnerabilities and risk factors is really important.
I suppose actually, Michelle, just one thing I would like to add, and I think that everybody that's listening today, or a lot of us, would have done the MARAM training at this point. And I think, you know, I keep thinking back to how important and how great this piece of legislation is, the FIS, the CIS, MARAM, around reshaping the way that professionals see information sharing. I think that there's been an inherent fear that if we share information without express consent, that we're doing the wrong thing. But I think this really highlights the importance of that relevant information sharing in the best interest of children for safety and well-being. So what I really like about this is it's built into the legislation around, if you're sharing information for the right reasons in the best interest of a child's safety and well-being, then you're not doing the wrong thing. Because I think that's something we need to get past. If we hold information that could present a risk to a child or an infant that doesn't have a voice, we need to be sharing that to make sure that we're keeping children and infants safe, as well as victim survivors.
Yeah, and I really, you know, I think that's a really great thing you spoke about, Luke. And I think one thing, when the MARAM first came out, I think a lot of practitioners, including myself, went, oh my gosh, you know, we might be expected to be all trained up to be specialist children's risk assessments, and, you know, doing a risk assessment on a family with 5 children. And I think there was a lot of, you know, misguided information that we were all expected to do this work. Where, you know, that's, I think, Michelle, you spoke about it previously in another meeting, where, you know, as long as we're keeping children, young people, and infants in view in all of our work when we're working with victim survivors of family violence, that's what we need to bring. You know, I think that's the core focus that we all need to be thinking about when we're working in family violence and using the MARAM.
Yeah.
Well, thank you very much to our panelists. This we really see this as the beginning of a conversation, not the end of it, and to continue to discuss, you know, how we can improve our practice. I think what I'm taking away is the fact that, in particular, when it comes to infants, that, you know, as Luke said, you're giving them a voice where they may not have one. They do have a voice, but we can't necessarily know what it is they're trying to communicate. But the very real impacts are there. So even though somebody may not be able to articulate their level of distress, they can modify their behaviour and accordingly. So there's hopefully a few things that you're all going to take away today, but I think there's the three things that we can actually really focus as a family violence sector is more in education about the impacts of children. Impacts of children. I know the impacts of children. I've got two myself, but the impacts on children of family violence. Acknowledgement of the children's unique experience, so and vulnerabilities, and their own experience, which is can be very vastly different to others in the family, and absolutely develop and identify opportunities for cross collaboration, secondary consultation, having that discussion. So I'm just hoping that everyone is taking away from this the realisation that we can actually work together to ensure the ultimate risk and response for infants experiencing family violence. And with that, I'll say goodbye.